We have again Professor Hamm to tell us about anatomy versus function in terms of complete revascularization.
Yes, thank you again. I'd like to continue and address the question, what is complete revascularization? And the title here is anatomy versus function, but I like to extend it anatomy versus function versus physiology. If we intend to revascularize patients, we're usually guided by the anatomy because that's the coronary angiogram. And the angiographic definition of the completeness of revascularization is usually based on what we see on the angiogram, and that's what it is, the diameter stenosis. So that's what I call the plumber's doctrine. And because that's what we are accused as interventional cardiologists also as the oculostenotic reflex sometimes. Now, I think more important is the function, and as already shown by Philip Cole, is that our revascularization should be function guided. What is function? Function is the viability of the myocardium and is also the evidence of reversible ischemia. And what's behind this? Behind is that the amount of ischemia we see, or we can see by different methods here by scintigraphy, is related to the outcome. Patients that have mildly abnormal perfusion images as compared to moderately abnormal perfusion images, they have a poorer outcome. They have higher event rates, in particular in diabetic patients. The event rate is much higher related to the extent of the ischemia. We learned from the CABG trial that the cutoff should be about 10%. If more than 10% of the myocardium is at risk or ischemic, then the outcome of these patients is at risk. If there's less ischemia, below 10%, then the outcome is less effective. But any area that shows more than 10% ischemia, or any vessel that supplies a territory of more than 10% of ischemia, myocardial ischemia, should be revascularized. So that's what is defined as completeness in terms of ischemia or function. I think even more important behind than function is the physiology, because that's what the final aim is, that we should improve physiology. And physiology means what is the flow in the arteries, or what is the flow not only at rest, but also what's the flow under stress, under exercise. And it's also already been shown by Philippe that FFR today is the standard. What is FFR? FFR is relation of the pressure that we have proximal, distal to the stenotic lesion in relation to the proximal part, and then if that relation is less than 0.8, it's considered to be abnormal, because relation of less than 0.8 is also linked to a poor outcome in these patients. This is how it's measured in the cath lab. You see here an original tracing. The red line here is the pressure proximal to this lesion, and the green line is the pressure that's measured distal to the lesion. And then what you do is you give the patient adenosine to get maximal hyperemia in this artery, and you see that this pressure gradient drops, and in this case it's 0.58. So it's a highly significant lesion in this patient, and this lesion then is linked to outcome. Like here, this patient with a double vessel disease at first sight, this high-grade lesion probably doesn't need FFR. This is most likely to have abnormal FFR. But about this LAD lesion, we really don't know whether this is really significant, whether this is abnormal. Has abnormal FFR, but you as surgeons probably would always put a Lima graft on this LAD, and we probably also as cardiologists tend to place a stent in this lesion, but if it's justified, that's the question. So the message behind is what you see in terms of anatomy is that really what you get at the end, and anatomy may be quite irritating sometimes. That's a lesson. And if you look at the different lesions that are angiographically classified between 50, 70, 71 to 90 or 91 to 99%, and you look at the FFR, of course the high-grade lesion, almost all cases have abnormal FFRs. Patients that have an intermediate lesion, also the majority of patients that have abnormal FFRs. But stenosis between 50 and 70%, these lesions, you find only in about half of these lesions abnormal FFRs. So they are hemodynamically not relevant, these lesions, and therefore should not be treated. I'd like to show you an example. Again, this is a patient with double vessel disease, has a very high-grade right coronary artery lesion, and this does not need FFR. And in fact, FFR was done, was abnormal, was treated, and this patient had another lesion. It's in the LAD here. And this probably is regarded as 70%, and it's very tempting to put in a stent here or to place a Lehman graft on this. But the FFR was this here. It's a screenshot, so it's not high quality, but you can read it's 0.82. So that is above the limit of 0.8. So this lesion does not need to be treated, and this patient now that started out as a double vessel disease now is a single vessel disease patient. And this is what you find if you look systematically at angios. In this publication here, all patients had triple vessel disease on angiograms, but if you do FFR in these triple vessel disease patients, then only 14% of the patients ended up to have triple vessel disease. 43% of the patients had double vessel disease. 34% of patients had only single vessel disease, according to FFR. And 9% even patients had no relevant lesion at all, so they did not need revascularization at all. Now, as already mentioned by Felipe, the trial we always refer to as the FAME trial, published in the New England Journal in 2009. And this was the protocol, as already shown to you. That was the angiography arm, and that was the FFR arm. And that was the outcome already demonstrated to you, that patients that were in the FFR arm had a better MACE-free survival as in the angio-guided arm. And the results are here summarized that by FFR reduces the rate of composite endpoint of death myocardial infarction, re-PCI and CABG at 1 year by 30% if you use FFR instead of angiography only, and reduces mortality in myocardial infarction at 1 year by 35%. That was the reason why this trial was prematurely stopped, because the results with FFR were so convincing. And that's why it has become standard in many cath labs, particularly in lesions that are intermediate, and it also will be seen in the new guidelines that this FFR plays a major role today. Here you see the guidelines, the recommendation 1A, recommendation to use FFR. Other data for surgery, there's one study, interestingly, published last year for surgery using FFR. And first, you see here the protocol, the angio-guided revascularization, the FFR-guided revascularization. After FFR, the number of triple vessel disease of significant stenosis was reduced from 93 to 86%. And this resulted in then by the surgeons in different rates of anastomosis. So there were much more single or double or triple anastomosis, and much less, significantly less 4 and more anastomosis placed in patients that had FFR during their diagnostic angiogram. So this did influence the strategy of the surgeon. And here the outcome, very similar to what you have seen in the FAME trial, is that the FFR-guided occlusion rate, it's not hard endpoint, but it's occlusion rate, the overall occlusion, graft occlusion was much better in FFR-guided grafts as compared to angiography-guided grafts. So somehow the results we have seen during PCI probably also translate into results during surgery, and that's why surgeons also should consider, particularly for intermediate lesions, to ask their cardiologist to perform FFR in the lesions. So physiology beats function, that's my message. If you look at the angiogram, it's not only anatomy, but function is also very important. Thank you very much for the attention.